welcome back to A to Z Dentistry, a channel which features easy explanation of various dental related topics. And our today's topic is hot tooth, right? So without any further delay, let's get started. So today we will be studying hot tooth under the following subheads. First, we'll look at the introduction, that is what exactly is hot tooth, followed by the definition, pathogenesis, and the management of the same. So hot tooth is a type of endodontic emergency. Okay, that means this condition is extremely painful for the patient and it requires quick management by the clinician. Okay, so it is an example of endodontic emergency. So basically, endodontic emergency is a condition which is associated with pain or swelling that requires immediate diagnosis and treatment by the clinician, right? So pulpal pathosis and traumatic injuries are the most common type of such emergencies, right? And this is one of the example. So pain in endodontic emergency is mainly related to two factors, that is due to the release of chemical mediators which is occurring due to chronic inflammatory process as well as the pressure, as there is increase in the edema which is formed, right? Therefore there is release of certain chemical mediators like prostaglandins and all, which contribute towards significant pain, which is the main feature of endodontic emergencies. Moving on towards the definition, right? So, a tooth that is difficult to anesthetize is known as a hot tooth. So, the most commonly encountered tooth is mandibular first molar, right? Wherein after giving the anesthetic block, the patient may describe all the subjective and objective symptoms, right? There would be profound numbness of the ipsilateral lip and tongue as well. But still, there is acute pain during the procedure of access opening. Now, why this is happening? It is because of release of those inflammatory mediators, right? So, even after giving for example, if we take into consideration mandibular molar, if we are giving inferior alveolar nerve block, still there is pain to the patient while the endodontic procedure is going on, right? So such a tooth is known as hot tooth, right? In which even after giving anesthesia and even after there is presence of all the subjective and objective symptoms of right anesthesia, still there is acute pain to the patient. Moving on towards the pathogenesis, right? So, as we know that C fibers are mainly responsible for carrying the sensation of pain from the affected area towards the brain, right? So, there is a special class of sodium channels which are located over these C fibers. These are known as tetrodotoxin resistant sodium channels, right? As we know that sodium channel play a very important role as far as induction of anesthesia is concerned. So there are two types of these channels which are located over the C fibers. The first one being tetrodotoxin resistant or sodium channels, and tetrodotoxin sensitive sodium channels, right? So we need this tetrodotoxin sensitive channels in order for the anesthesia to act, right? But what happens is that there is a chronic neuroinflammatory responses which are occurring, right? As there is bacterial infection, there is pus formation inside the tooth, so there is change of expression from these tetrodotoxin sensitive channels which are more sensitive to our local anesthesia towards tetrodotoxin resistant channels which are relatively very less sensitive towards lignocaine, right? So this is the pathogenesis, right? And because of this shift there is profound pain to the patient as there is change in the channels which are present over the sodium channels, right? So one of the clinically significant characteristic of the sodium channel is that they are relatively resistant to lignocaine, right? And these channels are 5 times more resistant to our anesthetic as compared to tetrodotoxin sensitive channels. So the pathogenesis which is responsible for this hot tooth may be explained by the fact that the tetrodotoxin resistant sodium channels haven't been completely blocked by the anesthetic agent, no matter whichever anesthetic agent we are using, right? So these are relatively rendered ineffective because of this conversion from tetrodotoxin sensitive sodium channels towards tetrodotoxin resistant sodium channels due to the inflammation which is going on, and because all those chemical mediators are being released at that site, so this conversion occurs and therefore there is acute pain to the patient while the access opening, and while any other endodontic procedure there is immense pain to the patient. Moving on towards the management part or the treatment part, right? So the first modality is supplementing an inferior alveolar nerve block, right? So this technique usually is done with the help of 4% urticane. So rather than using lignocaine, we are using 4% urticane with 1 is to 1 lakh epinephrine or adrenaline, and we are doing the buccal infiltration, right? And this is done at the apex of the tooth, right? So the tooth which has to be treated, we are injecting this solution at the apex, and this is one of the most effective supplemental anesthetic technique which can be undertaken in such cases. Our next treatment modality would be buffering the LA, right? So buffering means we are adding some other solution to our LA. So what is the signification of this buffering? So what this buffering does is that it will increase the dissociation rate of the local anesthetic molecules, right? And thus it will increase the unchanged base form that crosses the nerve membrane towards the intraneuronal site where it can exert its action, right? So we know that whenever we're injecting an anesthesia inside the membrane, it gets dissociated, right? So therefore we need more of the unchanged base form, right? Because that is the form which can easily cross the nerve membrane and exert its effect. So this is the function of buffering. So buffering or alkanizing the dental local anesthetic solution immediately before its administration with stabilized sodium bicarbonate solution has been found to make the onset of anesthesia more quicker in a hot tooth, right? So basically we are increasing the unchanged base form for quick action, right? We need quick pain relief, so we can also use this technique, that is buffering. Immediately before injecting the LA, we can add the stabilized sodium bicarbonate solution. So our next technique would be supplementary intraligamentary injections, right? So for this intraligamentary injection, we need a volume of about 0.2 ml of LA, right? And this is deposited slowly using the short needle. So here the position of the needle is slightly important as we need to inject it within the PDL space. So the bevel of the needle is placed into the PDL space on the mesial aspect of the first molar if that is our affected tooth. So either we can use the mesobuccal or the mesolingual aspect, and the bevel should be facing the root of the tooth. And in such a position, the needle is advanced into the periodontal ligament space until and unless we uh, experience a firm resistance, right? So when the resistance is encountered, at that time we slowly deposit our LA, right? So this techniques helps to gain a profound anesthesia. Our last technique is intrapulpal injection. So it is nothing but directly we are injecting into the body of the exposed pulp. Now this technique has to be performed only when the pulp is already exposed, right? So we need a large needle, right? So we need a hypodermic needle to undertake this procedure. However, this is immensely painful for the patient, right? So you know that pulp is already a highly vascular tissue, so when you are injecting into it, it is very painful for the patient. However, this is also one of the practice technique in case of hot tooth. So let's have a quick recap what we have learned so far. So we started with the definition, that is a tooth which is difficult to anesthetize is known as hot tooth, right? Then we moved on towards the pathogenesis, that is how exactly this is happening and why the tooth is resistant to anesthesia. The reason being is activation of tetrodotoxin resistant channels which are 5 times more resistant towards the LA solution because of the neuroinflammation which is going on within the tooth. Then we had a look at the treatment modalities which are available, right? So first was supplementing our LA with the help of urticane, right, with addition of epinephrine. So this is also one of the most widely used technique. The concentration we are using is 4% urticane with 1 is to 1 lakh epinephrine solution, right? Second, we looked towards the procedure of buffering, right, in which we are using sodium bicarbonate so that more amount of the base form of LA is available for quick action and relief to the patient. Third, we looked at the intraligamentary technique wherein we were injecting the LA directly into the PDL space. Then we had a look at the last technique, that is the intrapulpal injection, which is only given in case the pulp is exposed, right? So this is all we have learned. I hope you understood the topic very well. So this was all about hot tooth, guys, right? So this is a very important short answer question which is asked in your exams. I hope you understood this topic very well. Thank you. This is Dr. Snehal signing off. Till then, bye bye. Take care.